Positioning Lesson 2 is Abdomen Radiography, the KUB, the Acute Abdomen Series, and Bowel Obstruction Patterns. The abdomen is one of the most clinically important exams in general radiography. 12 minutes. The AP abdomen, KUB, stands for kidney, ureter, and bladder. The patient is supine on the table in a true AP position. Mid-sagittal plane, perpendicular to the table. Both ASIS equidistant, no rotation. Arms alongside the body and out of the field. Legs extended. Technical setup. Ishi, 40 inches. KVP, 70 to 80, moderate penetration for soft tissue differentiation. MES via AEC center chamber or manual technique. Grid, required. Virtually every adult abdomen exceeds 10 centimeters. IR, 14 by 17, long axis vertical. Central ray, perpendicular to the table, 0 degrees. 4 KUB, center at the level of the iliac crests. This places the CR midway between the symphysis pubis below and the upper abdomen above, ensuring kidneys, ureters, and bladder are all included on the image. 4 upper abdominal exams, center to the level of the xiphoid process instead. 7 evaluation criteria for the KUB. Symphysis pubis to the lower poles of the kidneys must be included. Both iliac wings visible and equidistant from the spine. No rotation. Spinous processes centered between the pedicles. Psoas muscle shadows. The bilateral diagonal lines from T12 to the pelvis. Visible with sharp lateral margins. Both kidneys visible at the T12 to L3 level. The right kidney is normally lower than the left. Gas pattern visible throughout colon and small bowel. Proper exposure. Bony cortex visible and differentiated from soft tissues. Key anatomy to identify on every KUB. Liver, right upper quadrant, inferior margin visible. Spleen, left upper quadrant. Kidneys, bilateral, right normally lower than left. Psoas margins. Their sharpness reflects retroperitoneal fat planes. The gas pattern. Haustral folds in the colon do not extend fully across the lumen. Valvuli. The circular folds of the small bowel do extend fully across. That difference in fold pattern is how you distinguish the two on the radiograph. And the symphysis pubis must always be included. The acute abdomen series consists of 4 views, and each one answers a specific clinical question. Supine AP abdomen. The standard view shows the bowel gas pattern, identifies obstruction, ileus, masses, and calcifications. Air fluid levels are not visible in the supine position because gas floats to the top and fluid settles to the bottom. There is no interface to see. Upright AP abdomen. The patient stands or sits. The beam is horizontal, mandatory for demonstrating air fluid levels. When bowel is obstructed and fluid accumulates, the gas-fluid interface becomes visible as a horizontal line inside the dilated loop. Stepladder air fluid levels in the central abdomen are the hallmark of small bowel obstruction. Upright PA chest, always included in the acute abdomen series. Its specific purpose, detecting free air under the diaphragm, pneumoperitoneum. Free air from a perforated viscus rises to the highest point of the abdomen, the right subdiaphragmatic space, and appears as a crescent of dark air under the right hemidiaphragm. The patient must be upright for at least 5 minutes before exposure for free air to rise to that position. Left lateral decubitus, ordered when the patient cannot stand for the upright view. Patient lies on the left side. Horizontal beam. Free air rises to the non-dependent right side of the abdomen and is visible between the liver and the right lateral abdominal wall. Also demonstrates air fluid levels in bowel loops. 5 patterns. The registry tests each one. Small bowel obstruction. Dilated central bowel loops greater than 3 centimeters in diameter. Valvuli, the circular folds, extend completely across the lumen. Central abdominal location. Stepladder air fluid levels on the upright view. Paucity of gas in the colon. The colon is decompressed because nothing is getting past the obstruction. Large bowel obstruction. Dilated peripheral bowel frames the abdomen. Haustral folds that do not extend fully across the lumen. Diameter greater than 6 centimeters. The cecum is the most distensible segment. Cecal diameter greater than 9 centimeters is critical and carries risk of perforation. Paralytic ileus. Diffuse dilation of both small and large bowels simultaneously. No mechanical obstruction. The bowel simply has stopped moving. Common after surgery, with hypokalemia or after abdominal trauma. The entire gut is uniformly distended. Pneumoperitoneum. Free air under the right hemidiaphragm on the upright. On the left lateral decubitus. Free air on the right non-dependent side. The most common cause is perforated peptic ulcer and calcifications, kidney stones, radio-opaque, in the renal collecting system or ureter. Appendicolith, right lower quadrant. Phleboliths, round pelvic calcifications with a lucent center, not to be confused with ureteral stones. Gallstones, only 15% are radio-opaque. Ascites, increase MAS significantly, 50 to 100% above standard. Peritoneal fluid accumulation adds tremendous density to the abdomen beyond what the centimeter measurement alone predicts. Gas-filled bowel obstruction or ileus. Decrease MAS 25 to 30%. Gas attenuates less than normal soft tissue. The standard technique overexposes. Obesity. Increase MAS substantially, up to 70% above standard. Cachectic patients. Decrease MAS by 25 to 35%. 3 special views. AP pelvis. CR at the ASIS level. Demonstrates iliac wings, sacrum, SI joints, hip joints, and pubic symphysis. AP oblique abdomen. 45 degrees of rotation. Demonstrates the elevated kidney and ureter on the oblique side. And IVP time series. Films at 5, 15, and 30 minutes post-injection track contrast moving from the kidneys through the ureters into the bladder. 3 abdomen radiography questions. The answer is C, small bowel obstruction. Dilated central bowel loops with valvuli that extend completely across the lumen, combined with absent colonic gas, are the hallmarks of small bowel obstruction. The valvuli, circular folds, are the key distinguishing feature. In large bowel, haustral folds do not extend across the full width of the lumen. Central location and the step, latter appearance on upright views confirm small bowel. The answer is B, left lateral decubitus with horizontal beam. When a patient cannot stand, the left lateral decubitus position is the substitute. The patient lies on the left side, and the horizontal beam allows free air to rise to the non-dependent right side of the abdomen, where it appears as a crescent of dark air between the liver and the right lateral abdominal wall. The horizontal beam is essential. Free air cannot be demonstrated on a vertically directed beam regardless of position. The answer is B, the level of the iliac crest, midway between symphysis and diaphragm. Centering the CR at the iliac crest level places it midway between the symphysis pubis, the lower border, and the upper abdomen, the upper border, ensuring all 3 organs of the KUB are included on a 14 by 17 image. The symphysis pubis must always be on the image for the study to qualify as a complete KUB. Lesson 2 complete. You covered AP abdomen KUB positioning and technical setup, evaluation criteria, and key anatomy, including psoas margins and the valvuli distinction. The full acute abdomen series with its 4 views, bowel obstruction pattern for small bowel, large bowel, and ileus, pneumoperitoneum detection, and pathology technique adjustments, including ascites.